I'm Brad Erickson, Associate Professor of Urology at the University of Iowa. Specialize in reconstructive urology and men's health. In men that are undergoing surgery or radiation for prostate cancer, the risk of having some degree of incontinence after that surgery is very high, over 50%. Now that's not a long-term incontinence rate, but it is something that should be expected and conveyed to them that if they have that amount or degree of incontinence, that it will likely improve with time. They also need to know that early intervention and early discussion about the incontinence and the leakage issues can be advantageous to the patient because things like urethral bulking agents, Kegel exercises, and then things like sling and artificial urinary sphincters can be placed earlier on in their postoperative period so they don't have to go through the stress and anguish of having stress urinary incontinence. Now, other pelvic surgeries that don't involve the prostate can also cause problems with urinary symptoms because the nerves that supply the rectum can also supply the bladder. The issue in men that are having APRs or resection of the rectum for rectal cancer or colon cancer, they can have problems with urinary retention, in which case they often need to do some amount of intermittent catheterization to try to empty their bladder. Now again, this is something that is good to know preoperatively or pre-radiation because with time this will also often improve. The earlier the referral comes, the better, if not just to provide the patient and provider with peace of mind, but also so that the urologist can triage the patient and identify ones that are more likely to need some type of future intervention. Hi, Mr. Tucker.
Hey, how are you?
Dr. Erickson.
Yeah, good to see you.
Nice to see you too. So what is it that brings you into the clinic today?
I had prostate cancer surgery about a year and a half ago and still having issues with leaking and erectile dysfunction as well.
Okay, let's start with the incontinence first, the leakage. So is this something that occurred before your prostate cancer surgery?
No, it right after. I mean, I just had no control.
Now, is the incontinence improving over time?
Back, it seemed like it was kind of bad in the beginning. Maybe I saw a little improvement, but now that I'm, a year and a half out, it really is no good. It's bothering me a lot.
I assume you're using pads and or Depends?
Yeah, I just carry a bag of pads with me no matter where I go, and some days I use up to 5, and other days it's 10. It just varies on what I'm doing.
Okay. So the more active you are, if you're lifting things, that's when you notice that your incontinence or leakage is worse.
Yeah, it seems to be worse when I'm doing some exercises or work around the house.
Okay. When you say 5 to 10 pads, are those pads usually soaked, or are they just a little drip of?
Pretty soaked.
Pretty soaked.
Yeah.
Let's talk a little bit about your expectations and goals for some type of intervention for the incontinence. You're 18 months out now, and you're using 5 to 10 pads per day. Would you say this is affecting your quality of life?
Yeah, I mean it's to the point where I'm at my wit's end. I can't leave the house. I don't feel good about going out golfing with my buddies. Grandkids coming over to the house is kind of, I just feel bad. I can't play with them like I used to. It's changed my life. I mean, I'm always thinking about where the bathroom is. Always thinking about pads. I've got pads in every coat pocket, and it's changed everything.
What is your goal for treatment?
I just want to be dry. I just want to be able to leave the house and not feel like everybody knows that I'm leaking. I feel like I sometimes smell. I feel like there's just, my quality of life is just diminished terribly.
Okay.
If I could be half as dry, if I could just leave the house with 1 or 2 pads and know that those would keep me dry all day, it'd be changed.
I think the most important thing that a non-urologist oncology colleague can ask patients that have had pelvic surgery, either rectal cancer or prostate cancer or even bladder cancer, would be, are there urinary or sexual things that have happened since surgery that are affecting their quality of life? Specific questions would be, especially in men that have had rectal cancer, would be the feeling emptying or the onset of urinary incontinence. A lot of times that can be because their sphincter is not as functional or their bladder is not contracting as well. If they've had prostate cancer, it would be the amount and degree with which they're leaking. I think that it would be very reasonable for an oncology nurse to teach basic Kegel exercises to all patients that have undergone pelvic surgery. And then finally, when you're asking, when the patient is asking about is there a treatment or is there somebody that I can talk to, I think the earlier that you refer them to a urologist to discuss both erectile function or sexual functioning and urinary incontinence, the better. There are really 4 main treatments that we can provide for stress incontinence after pelvic surgery. The biggest one, and the one that can be offered by anybody, is Kegel exercises and pelvic floor exercises. What happens after surgery in the pelvis is that the urinary sphincter mechanism that's intimately involved with the rectal sphincter mechanism, those can be damaged and they don't function as well, and this can often lead to stress incontinence. Now, a lot of times the sphincter is still present, it's just not as active and robust as it used to be, in which case Kegel exercises, which both strengthen the pelvic floor, but also give the patients more understanding about how to control it themselves, can be a mainstay of treatment regardless of severity. The second thing that can be done, and this is often done in the months after surgery if the incontinence is mild to moderate, would be to do injectable therapies called bulking agents. Those can be used to build up the sphincter mechanism or almost provide a little bit of obstruction within the urinary system to help with the incontinence. That is generally thought of as a short-term cure or short-term option for incontinence, the hope being that if the injectables are provided initially, that with time that sphincter function will improve and their incontinence will improve. The biggest divide then are the surgical interventions for stress urinary incontinence. If men have not been radiated and they have mild to moderate incontinence, which is generally 1 to 3 or 1 to 4 pads per day, and they can start and stop their urinary stream, which gives us some indication that they have some residual sphincter function, then a advanced sling or a sling that is placed underneath the bulbar urethra can be utilized. That sling is thought to both provide a moderate amount of compression of the urethra, but also reestablishing the urinary sphincter to its more anatomical location, and has been shown to be very good at reducing the amount of incontinence in up to 85% of patients. Now, as the amount of incontinence goes up, or in radiated patients or patients that just have overall higher degree of stress urinary incontinence, the artificial urinary sphincter can be placed. Now, this is a significantly more involved operation. There are moving parts. Fluid is transferred from one location in the body to another. A pump is placed in the scrotum, and that opens and closes the sphincter. But when compared to all other options, it's still considered the gold standard and is the most effective at decreasing the amount of incontinence in men. Of course, the last 2 options are would all require a significant amount of consultation with the urologist, and generally are not placed in men for about a year after their initial surgery. I would say that the take-home message for all providers that are dealing with male cancer survivorship issues, specifically male pelvic cancer survivorship issues, are that there's no amount of dysfunction that can't potentially be improved. And the earlier that the men know about this, and the earlier they go see a men's health or cancer survivorship specialist, the better off the patient will ultimately be.
Hi, my name is Amy Pearlman, and I'm a men's health specialist. Hi, my name is Dr. Pearlman.
Hi, Dr. Pearlman.
How are you doing today?
I'm doing great. How are you?
Awesome.
Good.
So today I'm going to talk to my patient about restoring his sexual function. So what can I help you out with today?
Well, I had a radical prostatectomy about 5 years ago,
Okay.
and haven't had any luck with erections since.
Okay.
So I'm here to see if you can help me.
Awesome. Well, I'm happy to have you. Now, have you tried any therapies before?
I really haven't. No, this is the beginning for me.
Okay. So we have a lot of options to restore sexual function, and so even when someone comes in and they haven't tried any therapies in the past, I will talk to them about the range of options that we have to offer. Do you have any significant heart disease, any prior stroke, heart attack, chest pain?
No, I'm pretty healthy other than the prostate cancer.
Okay, and you don't carry around nitroglycerin in your pocket?
No.
Okay, so based on what he's telling me, he has no contraindication to try an oral therapy like Viagra, Cialis, Levitra. I tend to prefer Cialis because its half-life is much longer. So someone could potentially take it on a Friday night and it might still work for them on a Saturday. That's not necessarily the case with Viagra. So you have the pills, and then other people might want to use a vacuum erection device. So that's a completely external device. You can buy it commercially online. The nice thing about the vacuum is that once you buy it, you own it. There's no additional cost to that. It's an external device. You put it on the penis. It draws venous blood into the penis. And then typically people will put a ring around the base of the penis to keep the blood in. My patient right here is a fairly healthy young gentleman, very active. So in his case, I don't really think that's going to be a good option. I would typically use a vacuum erection device in maybe an older, sicker gentleman. So besides the vacuum device, we also have a urethral suppository. So that's a medication that he would put in the tip of the penis, and it acts locally on that tissue and can provide erections. Have you ever heard of injection therapy before?
I've heard about it.
Okay. So the injection therapy, you take a tiny needle about the size of an insulin needle. I find that my patients who are also diabetic who use insulin tend to tolerate this therapy well. Again, you place a needle in the side of the penis and it acts locally like the intraurethral suppository to provide erections. What I do tell people is, unlike the pills where it says on the box, it can give you an erection, painful, lasting greater than 4 hours. It doesn't actually happen with the pills unless you take an unapproved dose or you take it with other medications or drugs. With the injection therapy, you can get that phenomenon where you do get a painful erection lasting greater than 4 hours, in which case you do need to go to the emergency room for that. And then have you ever heard of the penile implant?
I have.
You have, okay. So the penile implant, I make very clear, is different from the external vacuum erection device, and oftentimes people think that they're both the same. The penile implant is a completely concealed device. We put it in through a single incision about this big, typically between the penis and the scrotum. It takes about an hour to an hour and a half to place. Technically outpatient, you stay 1 night in the hospital. When I talk to a lot of primary care providers, the perception is that this implant is an option of last resort, or that the infection and bleeding risk is super high. It's actually not. The infection risk is around 1 to 2%. The patient satisfaction, the partner satisfaction is actually very high. And so again, I talk about all these options in the very first visit because some people just don't want to do injections, some people don't want to do a vacuum, some people the medications don't work or they don't like the medications, and so all these options get spoken about. In terms of information I can provide to you as oncology providers, you know, at the end of the day, I want you to send your gentleman and their partners at any point in their therapy, whether it's before surgery and you expect that they might have a drop in their erectile function related to their treatment, either surgery or radiation, or at any point afterwards. It is never too early to have that conversation. Any questions I can answer for you today?
No, I think you've given me a lot of things to think about, and I'd like to study up and read a little bit more about them.
Awesome, thank you, and thank you for your time. The points that Dr. Erickson and I want to get across to you is that we have so many options for restoring urinary control and sexual dysfunction after either radiation or surgery for pelvic cancer. So please reach out to your local urologist or men's health specialist to talk to both you and your patients about the potential options. Thank you again.